And today I am here with Dr. Virginia Shaffer, who is an associate professor of surgery in the Division of General and GI Surgery and the Division of Colorectal Surgery. In the Department of Surgery, she's an associate professor, also works with the Winship Cancer Institute and Emory University School of Medicine. She's the co-director of surgical grand rounds in the Department of Surgery and is one of the scientific directors for the Emory Crohn's and Colitis Center. We're really happy to have you here today. Thank you for taking time out from your patients and your family to be here with us. How are you doing today?
I'm doing well. Thank you for the invitation and for the opportunity to be part of your program. I'm just excited to be able to kind of help answer questions for patients as best I can, especially during this COVID pandemic, which I think has everybody worried and anxious for their health and anxious in general. So thank you.
Absolutely. We are definitely all anxious. So today we're going to be focusing on COVID-19 and colorectal surgery. And so I'm just going to start right off. And if you have any questions, feel free to type them into the Facebook chat. And then I will try to cycle them in if possible. So the first question is, how is COVID-19 affecting colorectal surgeries, including access to care and necessary diagnostic testing?
So as you can imagine, COVID-19 is affecting everything about surgical care. And so early on in the pandemic, about mid-March, our healthcare system essentially shut down all elective surgeries, whether IBD or actually any surgery that was considered elective was shut down. We're still shut down from the beginning, I would say mid-March to now. Things were shut down for about 2 weeks when the numbers were pretty high. The only operations that were being allowed throughout the healthcare system were emergency or urgent, meaning life-threatening surgeries. Now we have loosened a little bit the restriction where any time-sensitive surgeries can take place, but it's happening on a case-by-case basis where we have to present essentially a case to kind of try to prove that this is that the benefit is greater than the risk in terms of going forward with surgery. So it's a case-by-case basis, week-by-week basis as of right now.
Okay. And do you feel that the IBD patients are included in the necessary surgeries, or are they less, I guess, they're not happening as often, and maybe like the cancer patients are occurring more often? Or is there a mix, or what's the mix look like?
So it's definitely a mix, but I will say that there is, I think, some institutional, some general public bias where time-sensitive cases are generally considered to be cancer cases, although there is a mix of some IBD cases. So depending on the type of case it is, so if someone is showing obstructive symptoms, can't be at home, things like that, I mean, those are considered either urgent or emergent cases. So those cases are going. Things that someone might think are emergent, but we are not considering emergent, are, say, if you have an ileostomy or a colostomy and you were scheduled to get it reversed. So as much as I hate to disappoint people, those are not considered emergency or urgent cases. So those are being delayed for cases where someone is either bleeding, perforated, or obstructed. So as of right now, those other types of cases are still delayed.
That pretty much answered my next question, which was, in the colorectal surgery world, what is being considered elective? And would it just be sort of the next step surgeries that are elective, or are there other surgeries that would be considered elective? And what surgeries are being rescheduled, and which ones are you seeing more so taking place?
Right. So when we first were canceling, we pretty much canceled all cases unless it was a life-threatening issue at that moment. So someone who's perforated, someone who's bleeding, someone who's obstructed, those were going no matter what. More recently, we are looking at, is this person, they're only obstructed some of the time, but they can't really be at home. So those cases are considered more time sensitive. So they are going as well. But I will say that probably the majority of the IBD cases are, I wouldn't call them elective, but they're not emergencies, and so those generally are not going. There are some like high output, so high output cases where the person can't stay hydrated for whatever reason, then those, are getting pushed to the front of the line.
Awesome. So for patients who are having surgery during a pandemic, how should they prepare? I mean, what's different? What should they do? Anything different? Obviously,
yeah. So a lot of things. Oh, hold on. Let me turn off my heater because I think it's making noise now.
Okay. It's definitely
I have a small heater. So I think things are a lot different. So even if follow regular CDC guidelines. So making sure you're hand washing, making sure you're not touching your face, social distancing, kind of all the normal things. When I have surgery, we have very strict visitor policy guidelines now. So people aren't allowed to come and visit you, essentially. And under special cases, you could have, like, if you live far away or you need a lot of help with your activities of daily living, then we're allowing someone to come stay with you for those reasons. But it's sad because a lot of people are undergoing big surgeries and don't have a family member or a friend at the bedside. So a lot of that kind of compassion care has fallen to the nurses, to the aides, to the people who mop the rooms, things like that, because people don't have that kind of family support or friend support that they normally would have if they'd undergone a surgery. So I think it's been lonely for the patients from that standpoint, and probably very hard for the families as well.
So would you recommend, like, bringing extra technology or like extra things to do if you're going in for surgery, or different types of activities? I'm not sure.
Yeah, I would just say to be prepared. Well, one, be prepared to have your surgery delayed if you're not in an urgent situation. And number two, if you are going to have surgery, also be aware that most of the COVID patients are in the hospital. And so we do a very careful job of trying to co-locate. So if you don't have COVID and you're having abdominal surgery, we are not housing you in the same unit as, say, the COVID patients. However, that's not 100%. If you go walk in the hall or go, like we encourage people to walk, then you could potentially be exposed, maybe not to a COVID patient, but maybe to a family member or somebody who was exposed to a COVID patient. So that can be kind of scary because, as we know, there are asymptomatic carriers. So one of the things we do is we are screening everybody who comes into the hospital, and we do have people stationed at our entrances to make sure that, one, they're supposed to be here because we want to diminish any foot traffic of people who shouldn't be, just exposing people. And number two, they'll ask you some screening questions. And then number three, we are testing for people that are going to go undergo surgery. We do have a rapid COVID test that is usually back within a couple of hours. So we know when we're going to operate on someone, unless it's an emergency, whether they're COVID positive or not.
Okay, great. What advice do you have for the patients who are at home who've had their surgeries postponed, who maybe aren't in the emergent category, but they're still suffering from like severe symptoms? We have a lot of IBD people in our community, who have obstructions or partial obstructions, abdominal pain, just severe symptoms. And a lot of people who are looking at surgery are having, very severe symptoms. So what advice do you have to everyone at home right now, just kind of trying to get through?
Yeah, so I think the best thing is to keep in good contact with your surgeon and with your physician. So I think letting them know, are your symptoms getting worse? Are you in a lot of pain? But I think a lot of IBD patients are kind of used to being in a lot of pain. So is this is this your usual, or is this getting worse? I think if you're getting worse at home, you should definitely be reaching out to your physician. Like, I've had patients who I've done things a little bit differently. So maybe I would have said, oh, come to the emergency room to get evaluated. So I'm trying to avoid sending people to the emergency room needlessly, because that's an area where they could get exposed. But saying, maybe come to a clinic during times that there are not other patients around. or so I could quickly evaluate them. Or maybe have them, if over the phone, if it's someone I know really well and I know that, whatever X, Y, and Z symptoms are, then sometimes I'll be direct. I just actually last week direct admitted somebody. Now that puts them, obviously they're in the hospital, so you have the same concerns about being exposed to COVID. But I think that if you're like suffering at home to the point where it's not, it's excess suffering for your situation, then I don't think staying at home is the correct thing. I think constant communication with your surgeon and your GI doctor is really important to try to decide, is this something that I can just kind of handle at home, or is this something that I need to come in for?
Yeah, I think that's great advice, and I always tell people, like, just talk to your IBD team. That's definitely great advice. Does colorectal or GI surgery in general make someone more susceptible to COVID or suppress one's immune system in any capacity?
You mean the surgery itself?
Mm-hmm.
Yeah, so we do know that surgery is essentially physiologic trauma. So we are purposefully putting your body through some stress. And so in those situations, we do know that your immune system can be suppressed to some degree. So yes, undergoing a big abdominal operation does make you to some degree more immunosuppressed than if you didn't. We also know that if you are COVID positive and you undergo an operation, that you don't do as well post-op as if you didn't have COVID. So that we know for sure, which is why we're testing people preoperatively, because we do not want to be operating on people who are COVID positive, because we know they won't do well.
Would you, if someone you're about to have, undergo surgery on had COVID, what would you do?
So it really depends. If it's an operation that is absolutely necessary, then we have protocols for keeping the patient safe and actually the healthcare workers safe in order to get them safely through the operation. We know they're going to have a rough post-op course, however. If it's an operation that can be delayed until the person is no longer having COVID symptoms, then definitely it will get delayed, even if it's especially if it's something that can be treated. So let's say your appendix. So if you come into the hospital with appendicitis, usually you get your appendix removed. But let's say you're COVID positive and you have appendicitis, then alternate treatments would be something like antibiotics in the hospital and bowel rest to try to get you over so that you don't need an operation while you're COVID positive.
That makes sense. So how, and this is sort of a hard question to answer, but how do we know if the risk of surgery during COVID is worth it? And who ultimately determines that? Is that more the patient and the provider? Is it a team decision? Does the institution or the facility get to weigh in? Or could you just run us through a little bit, like,
Sure.
how do you know we should go ahead and have surgery during pandemic times?
Yeah, so a lot of it is the resources that are available. So if there are no resources, then however much you or I want to do the surgery, it's not going to happen if there's no resources. So once you're past that, so the first level is, are the resources available at an institutional, at a healthcare level? Once we say yes, let's say the resources are available, then it's a decision between the patient and the surgeon and whether you want to pursue going forward. So now these are patients who are COVID negative, obviously. So COVID negative patients to undergo surgery. And it's a discussion about, you're going to be in the hospital where there are COVID patients. Are you okay with that? Are you okay with not having any visitors during your recovery? So it's really a kind of risk.
Do you want to wait? Like, you ask them, do you want to wait? I mean, is
Yeah,
that even
definitely. I definitely have had patients who, even for things like clinic appointments, who are like, you know what, I think I'm okay. I'll wait for, a couple months till I come in and see you. And we've also set up telehealth visits. So let's say you're an established patient and you just kind of want to check in. Then we do have that option for telehealth, so you don't have to come and get exposed in the clinics. And then even for new patients, we do have a system for new patient telehealth visits as well. So we're trying to accommodate, still providing the healthcare that people need without undue exposure to risk.
Great. Are there extra precautions that IBD patients should be taking if they're recovering from colorectal surgery, like things that they should have at home? Should they be buying more of things? What kind of advice do you have for the folks who are having surgery or recovering?
Yeah, so I think once you get home, the usual precautions are the same. So make sure you're washing your hands, make sure you're not touching your face, make sure you're social distancing. And then ideally you have one person who is going to be either getting your groceries delivered to you so that you're not having to go out. So I would definitely recommend that if you had an emergency surgery and now you're post-surgery and now you're going to be home, that you don't needlessly expose yourself to people who may get you sick, essentially.
That makes sense. And this is a great question, and something that I'm interested in definitely is, how do you recommend patients prioritize mental health during the pre, peri, and post-op stages? This is sort of a COVID question, but it's also sort of a little bit general. And is mental health counseling like regularly recommended by surgeons with and without the COVID fear? I mean, how does the mental health, with and without COVID, how does mental health play into all of this? And does it even come up in the clinic?
Yeah, so I think that's a really important question. It's actually one of my interests because I think that we often, as surgeons, treat the body and then kind of, okay, well, your obstruction's done, et cetera. And I don't think we forget, but we kind of put to the back that IBD, Crohn's, ulcerative colitis can be very chronic, lifelong illnesses, and dealing not just with the physical toll of that, but all the emotional and psychosocial aspects of it can be quite difficult. And some people have been diagnosed since they were, very young. And so they've had to grow up kind of dealing with that. So I think that's a different kind of stress that they're dealing with. So I usually do recommend kind of some mental health resources if the person is willing. I usually try to gauge how open the patient is about it, because I think some patients, when you bring up mental health, automatically, and it may be because they've had bad experiences in the past, automatically think that you're saying that their pain's not real, or that you're saying it's a mental thing, which I don't think that's not the message. The message is just that, yes, you have physical component to your illness, but having the mental health resources to help you deal with everything is important. Unfortunately, I think that a lot of those resources are not easily available. So either they're not easy to have insurances pay for them, or people just don't have that coverage. And so even though we can get people, charity care for their surgery, we really can't get charity care for mental services, which is really sad. I think that that dimension of kind of mental health as part of surgical care is slowly coming into light. I was at an annual meeting just before all this started, and there was an abstract presented looking at kind of how the correlation of anxiety and depression in some of our IBD patients. And in that specific abstract, it was actually greater than in, say, a patient who'd been diagnosed with malignancy. And so I think that it slowly but surely, that aspect of kind of overall care is finally making into the kind of the surgical arena.
I'm definitely glad to hear that. And I know a lot of people listening are also happy about that, because we talk about mental health. I mean, I think at every support group I've ever been to, or anything IBD related that comes up. And we actually have a couple of questions from the audience. And one of them is, if you're are you immunocompromised if your IBD is stable, but you have an ostomy or a J pouch, but are not on further medication?
No. So if you are not on any medication and you just have a history of IBD and you're not on any medication and you're stable, you're not any more immunocompromised than, say, someone with high blood pressure who also has an illness, but not really immunocompromised.
So not having the colon doesn't necessarily make you at higher risk or more immunocompromised?
No, it doesn't make you more immunocompromised. It does make you more at risk to being dehydrated. So you are at a lot increased risk of being dehydrated per se, but not specifically to, immunocompromised.
And would that be the same for folks who have ostomies and J pouches, or is the J pouch any different?
No, that would be the same.
Okay, great. How about for the patients that are on biologics or have a suppressed immune system? Maybe they're on a different immunosuppressant. Are there extra precautions for them if they need to have an emergency surgery?
Yes. So if you're on a biologic or steroids, then you definitely are considered in that higher risk group. And so, I mean, I guess the only extra precautions is knowing that you're in an immunocompromised state. And so doing all the usual precautions. Plus, I think people are still recommending wearing face masks. Actually, I think probably not quarantining is probably the best way to not end up getting COVID in that situation. You are considered. So if you're on a biologic and you're on or you're on steroids, you would be considered in that higher risk category.
Would someone who is on maybe say a biologic and getting surgery potentially emergently during this pandemic, would there be a chance that that person would be kept in the hospital further away from the COVID patients? Would there be a hierarchy of that of sorts, or not really?
Not really. I mean, I think that the goal is always to keep COVID patients separate from non-COVID patients. So non-COVID would just be considered non-COVID. And so they would be housed in the non-COVID. There's no hierarchy like non-COVID, more immunosuppressed, non-COVID, less immunosuppressed. So everybody who's not COVID, we would try to not house in the same ward. We have heard, if the numbers are really high, that there is a chance that you would have COVID and non-COVID. It would never be in the same room, but it may be in, opposite sides of the same ward. That has not really, we've not had to go there, but there is always a possibility.
So that's why we stay home. Well, yeah. For all of us that can, we stay home.
If you can.
Yes. You can. Right. Someone else had a question that's not totally colorectal, so feel free to let me know if you want to if you can answer it. But it says, does starting a new immune suppressing medication put you more at risk during this time? I mean, I think the answer is yes.
Yeah.
But.
Yeah, I mean, if you're starting a new immunosuppressant, yeah, you're going to be at more risk.
Yeah, so it just essentially increases the risk. But would you say that starting a new one during a pandemic is more risky than starting one not during a pandemic?
Well, I'll say this. I think if you're already on those drugs, you should never just come off of them. So what I don't want people doing is saying, oh my gosh, I'm immunosuppressed, I'm going to stop taking these medications, because I think that would be really, really bad. You can talk to your physicians about, let's say if you're on a steroid, like, is there any way to kind of go down on the amount that you're on? Not so much for a biologic, but like if you're on a high dose of steroids, potentially you could taper down. If you are in a situation where you're really needing, let's say you're very symptomatic and you need a biologic, I would say that you should go ahead and get it started and then follow extra precautions, because we don't know how long this pandemic is going to last. And if you're holding out for months and months and months saying, I'm not going to start my biologic, and most biologics don't work immediately either in terms of getting you to feel better. So what I would hate to happen is for people to be scared to start one, and then they wait months and months waiting for this pandemic to be over, and then they get to a situation where they're so sick from their IBD that now they need, an emergency operation because they waited so long. And I understand it can be scary, but I think it's scary to be really sick from IBD too. And so I think you have to kind of weigh that in your mind as well.
That makes sense. Thanks, everyone, for the questions. Feel free to add more, and we'll head on back to the colorectal world. So as you know, like home healthcare and post-op nursing care is like an important service, and it's truly imperative for optimal physical and mental health post-surgery. How is home health and wound and ostomy and continence nursing going to look like during this pandemic? Is it going to be different? What have you been noticing?
Yeah, so there's definitely a lot of differences. So a lot of the home health agencies that we use do have personnel, et cetera, that can still go and do their home health visits. So they wear masks and gloves and follow PPE precautions when they do their visits. What I noticed is definitely less number of visits. So if someone normally would have gotten maybe 3 visits a week, they're getting maybe 1 visit a week, because I think there's just not enough staff that are properly trained to do all those visits. Number 2, our wound care nurses have their own clinic here, but their clinics have also been diminished to reduce traffic through the hospital and through the clinics. So they are offering telehealth visits, which can be difficult, like if you have an ostomy problem, like how are you going to fix it over the video? But it can also be helpful because they can see, oh, you have skin breakdown here or there. And so they can offer some tips over over a telehealth visit that can help. So you're not completely alone. You can still have a telehealth visit. You can have a phone call. If you're really having trouble, our wound care nurses are seeing people in person. So you have all those escalation steps that, if you really are having, stoma problems or something that you really do need to see a wound care nurse, we do have availability for inpatient visits as well.
Awesome. Someone just asked, what telehealth apps are the surgeons using? Are you guys using anything?
Yeah, so we're using Zoom.
You're using Zoom?
Mm-hmm.
Okay, and do the wound, ostomy, and continence nurses use Zoom as well for telehealth?
Yes.
Okay, great. We had one other question, and I hope I say this right. Could dehydration due to the infection of COVID, so hold on, would COVID cause dehydration due to the infection, and are there increased concerns for those who have ostomies or ileostomies? And is there any data yet to figure out, okay, like say someone gets COVID, I'm assuming that's what the question is. Do you have COVID? You have an ostomy, so you're already potentially super dehydrated or at risk of it. Mm-hmm. Are you going to have maybe worse outcomes because you're just so dehydrated, or what do you have to say about that?
Yeah, so I think, yes, so ileostomy patients are already going to be at risk for dehydration. I think COVID, there are people who show GI symptoms with COVID, so diarrhea, GI upset. So if you have an ileostomy and you have COVID with diarrhea symptoms, then yes, you can become severely dehydrated. So I think in those situations, you probably are not going to be able to just self-hydrate at home. You probably do need IV fluids. And so I think that that's going to be something important to be in communication with your healthcare provider early on, because you can become very dehydrated very quickly. And so you need to kind of be monitoring that pretty quickly. But I think that if you have an ileostomy and you have diarrhea from COVID, you are most likely going to need inpatient care.
Okay. And then do you know if dehydration is something that COVID patients that are non-IBD, is dehydration something that is happening in COVID patients that makes people maybe think twice about hydration?
Yeah, I mean, I think some of them are because of the diarrhea, but most of the symptoms that we've seen are mainly respiratory. But obviously, when you're not feeling well, you're not eating as much, and you're not drinking as much. So there is that component of it that you're just not, the people who have mild symptoms, even they aren't feeling well. You feel like you have a really, really, really terrible flu. And those are the people with the mild symptoms. So as you get more symptomatic from COVID, then yeah, I mean, definitely hydration status is going to be important. Because some people do go into kidney failure, as they become sicker and sicker.
And is that mostly because they're not getting the fluids?
I don't think we know enough. No, I mean, and these people are in the hospital, so they're, I would assume, are getting IV fluids and things like that. So I think we don't understand all the mechanisms by which people are getting sick from this virus.
Okay, great. Yeah, we pretty much. There's still a lot of questions to be answered.
Yeah.
We have another question. Now that social distancing is likely to go on longer than we kind of initially thought, what do you recommend IBD and surgical patients do to prepare themselves for new normal, really in the healthcare world? IBD patients, we go to the doctor quite a bit. What do you think we should expect? And any tips?
I think one big difference, which may be good or may be bad, is that maybe you're going to be checking in more often using telehealth. So even after the pandemic, sometimes some of our patients live far away, like a couple hours. And so coming in to check, coming in just for a check may not be worth, a 3-4 hour drive. And so if you are doing well and you're just having a checkup, then maybe a telehealth visit with your gastroenterologist or your surgeon may be all that you need. And I think that in the end may end up proving beneficial for some patients. Obviously, the face-to-face, the person-to-person contact is important, and I don't think telehealth is going to completely remove that. I mean, you can't do a physical exam through telehealth, so that's a big thing that's missing. But I think that for kind of follow-ups and things like that, I think patients are probably going to start requesting, hey, I live 2 hours away. Can I just talk to you over the screen? And I don't have to drive in, mess with traffic, parking, et cetera. I don't have anybody to drive me, that kind of stuff. And so I think that that's one potentially positive side of this that may come out of it. I've been very pleasantly surprised that some of our older patients are very tech savvy. And so I thought that people weren't going to be able to figure out how to download Zoom and, do all the things we need to, but I've been very pleasantly surprised. I guess on the downside though, if you're someone who doesn't have the resources to have Wi-Fi or a laptop or a phone to connect, then that may put you at a deficit. But I think most people have phones now, and so the Zoom app works through a phone as well. And so we're hoping that kind of offsets some of that. But obviously, there's going to be some people where the technology is not there for them.
Is there anything else that we should expect, like in the clinics? I mean, are there sort of like social distancing lines, or is there a different mechanism in the clinic? Is it like, does everyone?
Yeah.
Wear a mask? I mean,
everybody is wearing a mask as we walk around.
To the patients, or does the patient like have to have one before they get there?
We're not requiring the patients to wear one unless they're having symptoms. All the staff are wearing them as you walk around or not, because you don't know if someone's an asymptomatic COVID person. So everybody is wearing masks as they walk around the hospital. I think there won't be, waiting rooms. The waiting rooms look completely different. And so I'm used to kind of walking through and seeing a lot of people sitting around in the waiting rooms. The waiting rooms in general, we've kept very empty for that reason. We used to have kind of coffee and things available for people to kind of pour themselves and help themselves while they're waiting. I think that's going to go away because of the infection potential. So some of the good things we may not be seeing, like the extra snacks while you wait or things like that may not be there. I think that the placement of chairs farther apart is something that you'll probably see. And I think a lot of people are doing the check-ins over the phone. And so a lot of the information that you would kind of sit down in front of somebody when you get to the doctor's office and tell them, all that is happening over the phone, like making sure your address is correct, your insurance, all the kind of that kind of stuff before you even see the doctor. I think a lot of that is going to be happening over the phone.
That's really great, especially because it just adds more time to your appointment and just keeps sitting there a little bit longer. We had another question from the audience, if you don't mind.
Okay. Sure.
Could you get a hernia from coughing if you have a stoma and you end up with COVID?
Yes, but you could end up with a hernia from coughing even if you don't have COVID. So yes, definitely increase of coughing, throwing up, anything that increases your intra-abdominal pressure can potentially give you a hernia if you have a stoma.
Okay, and so you're at a higher risk because the stoma is obviously protruding out of your skin.
Yes.
Makes sense. How long can you wait to have a bowel resection surgery? Is there sort of like a timeline? I mean,
it really depends. It depends on the reason that you're having it. So, let's say it's for a stricture. So, I mean, you could, if the stricture is not getting worse, it could be, I never say indefinite, but until you become symptomatic, which could be weeks, it could be months. Some people have narrowings for years before they have surgery, mainly their preference. So I think depending on the reason that you're having the bowel resection, and then what your symptoms are. Like if you're throwing up every day, then I don't think you can wait too long before having a bowel resection. So if you're throwing up every day, probably you can wait a couple of days. Let's say you're throwing up once every 3 months, then maybe you can wait a few months. And just if you don't even know, sometimes we find strictures on imaging and you're saying you're feeling great, then those people sometimes wait years before any surgery gets done at all. So it really just depends.
Wow. So the next question is, in general, IBD patients, they tend to work with a GI and a colorectal if they're going to have colorectal surgery. And we wanted to know, how do you handle tapering patients off of steroids, biologics, and immunosuppressants prior to surgery? And do you have any recommendations for patients to navigate conflicting provider opinions regarding steroid and immunosuppression prior to surgery, especially, when maybe the GI says one thing, the surgeon says another, maybe your rheumatologist or endocrinologist or like all the other doctors you see,
right,
maybe something different. Do you have any tips for like how you handle it personally and what you do, and also sort of general, how do we, help others advocate for themselves?
Sure. So that's a really good question. I'll start with me personally. So I don't like to operate on people who are on really high dose steroids. So I usually ask, in conjunction with their GI doctor, to taper down to at least 40 a day or less if possible. So, and the reason for that is mainly for wound healing reasons. So if we operate and you're on really high steroids, I think that the chance that you'll end up with a wound complication is pretty high. And we see that in the literature. And so I do work hard with the patient and with the GI doctor to get you down. What I do personally, so I'm at Emory and I work closely with our Emory GI. And so I have all of their cell phones in my cell phone and they have mine. And so normally if I see a patient on my schedule, that where I know the discussion is going to be, we're going to have, just talk about surgery. I usually have a discussion with that GI doctor to see where is that GI doctor thinking in terms of where this person is in their treatment and how close are they to really being medically refractory. And then also I try to get a feel for, do you think this patient is really ready to talk about surgery, so that I know how to kind of broach the subject, because I think it can be very scary to all of a sudden show up to a physician's office and be like, okay, well, this is a surgery you need, and sign this line and we're ready to go. So I try to get a feel. Usually the GI doctor knows the patient because they've been treating him medically for a while. So they usually can tell me, yeah, this person's ready to kind of have a frank discussion about surgery in the future, or this person's not ready yet, but they just kind of want to hear what their options are. And so that kind of frames what our discussion is going to be like. Obviously, when I get in the room, sometimes it's totally not what, it's a different frame of mind than what the GI doctor had mentioned, but it usually gives me a good idea of what the patient's needs, wants, and kind of frame of reference is. So I usually try to have that discussion. If someone's coming from an outside GI doctor that I don't know, I usually have that conversation after, because I don't know specifically which GI doctor they're being treated with. So after I have the discussion with the patient, then I usually ask them, who's your GI doctor, et cetera, get their contact information, and then have that discussion with them to see, so that we can come up with a plan. I think it's very, disconcerting for a patient to hear different things from different doctors, because then you don't know what to do. So I think the best we can to kind of align our advice is usually the best. And sometimes I'll discover that the reason they said X, there's a legitimate reason for whatever reason they said, and that we can come up with a compromise that is most beneficial to the patient. Here at Emory, we also have multidisciplinary inflammatory bowel disease conference once a month. where we actually, the surgeons, the GI doctors, and the radiologists all sit down and go over patients to make sure that we're coming up with kind of a unified plan going forward. And so we do that once a month because of that reason, to make sure that we're aligned.
Okay. And in terms of biologics and immunosuppressants, outside of trying to get patients off of steroids prior to surgery, what are your thoughts around getting folks, especially folks who need to get off medications prior to surgery, biologics, things like that? I know, like, is it different for Crohn's patients? Is it different for your colitis patients? What do you guys typically do, and how do you typically handle sort of the maintenance therapies, if you will?
If we know someone's gonna go to surgery?
Yes. So you have a patient with UC or Crohn's, and you know they're going to go to surgery. Mm-hmm. What do you do about their medications, and how is it different?
Yeah. So if it's a planned operation where we say, okay, you're on your biologic, and we're planning to go to surgery. So we usually try to time it where you're in between dosing. So let's say let's say Remicade, you're dosing every 8 weeks. I usually try to time your surgery around the 4-week mark. So you got your Remicade, 4 weeks later we operate, and then you get your Remicade again in 4 weeks. So ideally, we're not breaking up your schedule, and then I'm also operating on you at your kind of potentially lowest point based on your drug dosing. That's if you can plan ahead. So ideally, you're planning ahead, and we can look that into the surgery schedule. And so I will coordinate that with the patient and with the GI doctor who's providing the infusions, or whatever it is that they're on. In terms of, I think somebody had a question about the steroids. Yeah, I think it is really rough to cut down the steroids quickly. So if you're steroid dependent and you're on really high dose steroids, and then we cut you down, I think that can be really hard for patients. I don't cut people down if it's urgent. So if you're in the hospital and you're getting like methylprednisolone, which is the IV form of prednisone, we don't cut you down at that point, because we're saying you're medically refractory, and we're not actually creating any kind of anastomosis or anything. So when someone is kind of more of an urgent situation, and you're hospitalized and you're going to surgery because you're still having issues, you're bleeding, you're medically refractory colitis, those people were not, we usually don't taper down the way we do for elective cases.
Okay, great. And thanks for, acknowledging that sometimes providers have different opinions, and it's not always easy to be the patient. And it's also very stressful, and, then it taps into the mental health and everything.
Right.
A couple more questions, unless the audience has more, feel free to type in the chat before we end. But this is sort of another question, and it's a little bit more general, but I think it's really important. So why do colorectal surgeons, and not necessarily all, but why do some colorectal surgeons not always prepare patients who keep their rectums that they'll be passing mucus, blood, maybe stool sometimes, even when they're disconnected? And it seems that many people in our IBD community are not accurately educated or prepared for this part of surgery. I was wondering if you could speak to that, because I know some of our IBD community within Galley and elsewhere are really wondering kind of what's going on with this.
Yeah, so I think probably two things are happening, and it really depends. Probably two potential things, and it really depends on the situation. I think in some situations, I'll say, number one, you could be in a situation where the patient's very stressed. You just learned that you need an operation. You're going to end up with an ostomy. Like that, I think already sets off like a very stressful response. And so it may be that it was mentioned briefly, not emphasized, but mentioned. And it's not really something that you're hearing when you're hearing, I'm going to end up with a bag. So having some mucus come out your bottom may not really register. And so what I tend to do is I write down a lot of things on a piece of paper that has a picture of what the surgery is going to entail. I write the risks on one side and then the main things to expect. And then I make a copy of it and I give the original to the patient and the family. And then I keep one that gets scanned into the medical record. Because what I have found is sometimes, and I think it's just a stressful situation. The patient and the family member will come back and the patient will be like, oh, I didn't know X was going to happen. And sometimes the family member will pipe in and be like, no, I remember that was mentioned. Or sometimes neither remember. And I always say, oh, well, let's just look at our piece of paper that we talked about before we did the surgery. And I'll pull it up and sometimes they'll have it. I'm like, well, let's just go over and see, what part of this was not expected. And oftentimes they'll say, oh my gosh, it was written right there. And I just, it was not something, it's not like they're reading the piece of paper every day. It was just something that they initially looked at. They went through surgery, and it's not really like something that's like at the top of their mind. So, and you can't expect someone to remember every single thing. I think that's one situation. I think the other situation is that as surgeons, we may not be as focused on that part of it because you're focused on removing the stricture or dealing with X and dealing with Y. And so once that's gone and you have the ostomy, then maybe talking about the mucus that's going to be coming out of your rectum is not really something that people think to mention. It is interesting because I have had patients, so often I'll ask people to go ahead and do a Fleet's enema. Let's say they're disconnected. Let's say they have a colostomy and then a rectum that's unconnected. So I'll ask them to do a Fleet's enema before I do their scope. And people won't want to do it because they say, I don't have any stool coming out. I'm not connected. And so I always kind of say, well, I would really appreciate it if you did because your rectum makes mucus and secretions that aren't quite stool, but kind of look like stool and would block being able to do a good evaluation. And I think some people begrudgingly go ahead and do it and then are shocked when there's a lot of stuff that comes out. But I think it makes sense that if you're not connected, why would you be having stool? But it's not stool per se, but it's definitely mucus and secretions that look very similar to stool.
They probably didn't want to do the Fleet enemas because they're horrible.
They are.
My opinion.
They are horrible. They are horrible. So I totally understand. But sometimes people do think that there's nothing there. So often, because we do take a lot of pictures during colonoscopy, I go ahead and take a picture of the inside of their rectum so they can see that there really is stuff in there, even if it's connected.
But you definitely should. So the last question that we have, since I don't think there's anything else in the chat, was really, just how are you managing on the front lines? Like, what are the extra things that you and your colleagues are doing? How is everyone kind of holding up in the colorectal and surgical IBD world that you live in?
Yeah, I think we've been very, in a sense, lucky here in Atlanta. We haven't seen, at least in our healthcare system, and I don't think any of the other ones here in Atlanta, we've seen kind of the massive numbers that they've seen like in New York. Like we're not setting up, makeshift hospitals outside of our hospital because we don't have enough beds or et cetera. So I think overall we've been very lucky. Our supply chain has held up. We haven't had to make our own PPE or any of that stuff in collaboration with Georgia Tech and some of the other industries here in Atlanta. I think we've been very lucky in terms of our PPE. I think we've become more cautious. I think I used to just get a mask, go into the room, make sure that my instruments were there, toss my mask away, go around, come back, put a new mask, and then, do surgery. I think now we're being very conscientious about, if you grabbed a mask, just keep that one, in your pocket, and then you can use it again. You don't have to have a new one every single time. And so I think we've grown very conscientious of preserving PPE, but I think at the same time, we've been very lucky that we haven't run into the shortages that some of the other states have been reported in the news. From the surgery side, I think those of us that do a lot of elective surgeries have seen obviously like a down trend on that, but then an uptrend on other things like figuring out how to do telehealth. I never had done telehealth, so figuring that out, calling a lot of patients and telling them why they can't have their surgery is a stressful thing on many levels. We don't want to disappoint them, and I know that for many people that's a disappointing phone call, and I have hated making those calls just as much as anyone. Probably not as much as the person receiving it, but definitely not pleasant.
Hard,
so yeah, and so I think, disappointed a lot of people when we've told them your surgery is canceled. Most people have been very understanding, I would say, and understand that there's a pandemic going on and that we have limited kind of situation and scale of what we can do. We are hopeful that as the pandemic hopefully gets better, that we're able to now, kind of ramp back up. So I think those have been the main things. From the surgery side, I think the new normal is learning how to be extra careful in terms of, I think we were always careful about washing our hands and, the usual stuff. And we're used to working in a sterile field where you can't really raise your hands above your shoulders or below your waist. And so we're kind of used to that. But from an everyday standpoint, making sure you wash your hands more often than you do and wipe down high touch surfaces. And so I think that that's become the new normal. Our ICU colleagues have been working extra long. And so we have been called to volunteer to kind of backfill some of those roles. We have enough ICU support thus far that it hasn't been a problem. But definitely there were other preparations for us to be deployed if needed.
So that would be you being deployed to
within the system, like an ICU or the ER or things like that. So areas where I normally, don't really work. But that would only be in situations if that were needed.
Well, hopefully we will not need that, but I'm glad that you are there for backup for sure. Do you have any last words of thought or for anything for the community and those IBD warriors that are watching? Anything that you just want to say before we hop off?
Yeah, sure. So I just want to say thanks so much for the invitation, and it's been a lot of fun answering these questions, and I hope they were helpful to some people. I think that the main thing is to not be so fearful that you come off all your medications, because I think that could be pretty harmful. And if I could encourage patients out there to kind of really stay in close communication with their physicians, their GI doctors, and their surgeons, so that they don't feel like they have to make these decisions alone about whether they should have surgery or shouldn't have surgery. And a lot of these conversations can be had over telehealth or on the phone. And then also not to stay home if you really are having an escalation of symptoms, to really seek that medical attention. I know it's scary times, but it's kind of scary also just to stay at home and be super sick too. So, the best is to have that communication with your physicians so that you can make the right choice.
Okay. Yeah, no, definitely. Stay in contact with your medical providers. Thank you so much. Just to recap, if you missed the beginning, this is Dr. Virginia Shaffer, a colorectal surgeon at Emory Healthcare and Emory University School of Medicine. I'm Molly, a Galley Health Ambassador, and on Better Bellies by Molly online. And please follow Galley and let us know if you have any questions. We will be posting this video recorded for everyone to watch, so please feel free to share. And yeah, stay safe, everyone. I hope you stay well.
Yeah, stay safe. Thank you so much.
Yes, I really appreciate it.
Thanks. Bye-bye.
Bye.